Good morning. I'm really excited that you're here. I'm excited that you came on time. It makes my day better. Couple of announcements. One, I want to acknowledge another of the loss of one of our really extraordinary faculty members who's been around was around for 92 years, and that's Gordy Pine. Gordy Pine passed away this past week. Gordy was an extraordinary pediatrician across the street. He had joined Stanley at one point along the way, but was a major player in care of children and care of physicians' children, and served on our medical staff. So we'll miss Gordy a lot. He was an extraordinary person. I know many of you didn't meet him because in this last decade or so, he hasn't been around the hospital as much. I want to introduce Ben Wilfon from our ethics department. This is another of the Sconiers-Godfrey ethics sessions. He will give you a background on the design for today and introduce our speakers.
Thank you, Tom. It's really a pleasure to be here. And this time we do these twice a year, so this is the first time we've done this year since new interns began. So just to explain how this works, unlike traditional grand rounds, we actually will have about a good, hopefully, half hour for discussion. And we'll begin with a presentation, in this case by Lincoln Smith and Russ Sonato, about a case that they both were involved with. And then we'll have our commentator provide about 15 minutes of his thoughts about this case. And then we'll open for discussion. And so part of the reason for having the microphones on the aisles is because that allows both the questioners as well as the discussants to have an idea of who else wants to speak next, so we can kind of modulate that half hour better. So I realize that's a little different than we typically do, but that's the purpose of it, so we can kind of see if there's a long line or a short line, and that tells us how to go forward. Before I introduce our guest speaker today, I want to also mention a few other things about things that our bioethics center does. Every summer we have since 2005, we've had a summer conference on bioethics. Doug Diekema has been doing that conference now for 10 years. This will be our 10th anniversary. And we will be coming back to the original topic we did on the very first one, which are on ethical issues in clinical research. So, and we'll see what has happened in the last 10 years. So I'd encourage you to put that down on your calendars for July, I think, 18th and 19th, a Friday and a Saturday. On a different topic, our next Sconiers-Godfrey Grand Rounds will be in May, and that'll be on a very interesting issue regarding the question about caregivers' responsibilities in looking at or refraining from looking at parent blogs as a way of determining whether the parents have been fabricating their child's illness. So a very interesting question, quite different from the ICU. So I encourage you to come back here in May for that. And so let me end very briefly by welcoming our guest speaker before I have Lincoln Smith come up and present the case. But our guest speaker today is Bob Trug. Bob is a pediatrician. He's at Boston Children's Hospital. He is a former chief of the Division of Critical Care Medicine at Boston Children's, and is also the director of the Division of Medical Ethics at Harvard Medical School, and has been a thought leader in not only pediatric bioethics, but bioethics in general for the last too many years to count. Thank you. And it's really a pleasure having you here, and it's also a pleasure for me to have Lincoln and Russ be our case presenters. We've been working over the last few months to kind of put this case together. These cases are based on real cases, but we also do them as composites. So we change some of the information to make them a little more general, but they are inspired by real cases, and I really appreciate you coming here. So let me turn this over to Lincoln and have you take it away.
Good morning. Our patient is a 17-year-old young woman who is quite close to 18, who was happy, healthy, until she started to seize. She had had some prodrome for about 4 months previous to this, but relatively mild. I think not unlike what lots of people come into their general pediatrician to see for headache and some fatigue. Fortunately, her seizure did not break. It did not break following normal medical therapy, and she was eventually treated with a pentobarbital coma. After a month of refractory seizure, we finally obtained a diagnosis after a brain biopsy was performed. The diagnosis was of a homozygous mutation in the POLG gene, and she was diagnosed with juvenile Alper's Huttenlocher syndrome, which we have not seen too often in our ICU. So on Friday night, after a month of coma, neurology, genetics, and the pediatric critical care providers met with the family to present this diagnosis. It was presented as a variably progressive lethal disease with the natural course characterized by encephalopathy, epilepsy, and liver failure. The parents were also presented with a guarded potential for short-term recovery due to possibility of brain injury from the mitochondriopathy itself, refractory status epilepticus, and a prolonged coma in the intensive care unit. Over the weekend, her sedation and the pentobarbital were decreased in order to clarify her current neurologic function. Over Saturday and Sunday, the parents thought about their daughter and came to the conclusion that they prioritized quality of life over prolonging her life and request that she be extubated on Monday morning with the expectation that she would not survive. However, during Saturday and Sunday, as her sedation was decreased, Jennifer became more and more awake and much more purposeful, showing facial grimace and squeezing hands to command. So on Monday, I was the lucky winner of receiving this sign out and taking over the ICU service. We also had a turnover of the neurology service. And on Monday morning, when I went in to examine her, she was turning her head to her mother's voice. She was reaching out with her hands. She's breathing spontaneously. Despite these changes in her neurologic function, her parents were still insistent that given the prognosis, that they did not want her to survive this acute illness, only to die from encephalopathy, seizures, and liver failure. So I was concerned that if we honored the family's wishes and we extubated Jennifer in her current state and function, that she would not die. She would likely survive. And I had not participated in the initial discussions with the neurology and genetics teams. And it occurred to me that if her prognosis was as poor as it had been presented, and if it was reasonable for the parents to request that Jennifer be allowed to die at this acute phase of illness, I wanted to address the question of what will we do if she continues to breathe after she's extubated. And I asked for an ethics consultation regarding withholding food and water. And at this point, I'm going to turn this over to Dr. Sanito to talk about the diagnosis of Alper syndrome.
So good morning, everybody. It's a real pleasure to be here, and hopefully I can blow some of the dust off your biochemistry that you had in medical school. For those of you who are old enough like me who use Leninger, I have mine in my little thing. Those of you who use Stryer, I congratulate you as well. And those who used Hoodwood and Wilson, that's a good textbook too. But let me just set the background a little bit so you can understand a little bit about the physiology of this particular disease, because it's very interesting. As you know, mitochondrial disease produces most all the energy in the body. And it does this through a unique little factory called the electron transport chain. And in it, as you remember, when NADH is 4 and FADH2 is 4, it passes electrons down this chain in a process called oxidative phosphorylation. The only reason why we breathe is to produce energy via this transport complex. And what happens in the oxidative part is it goes down complex, certain number of complexes, and you get the reduction of molecular water from oxygen, the oxidation part. And then the phosphorylation part is making ATP from ADP, and that's what produces all the energy. Well, one of the mechanisms of producing the components for this electron transport chain is the mitochondrial DNA. Unlike any other organelle in the cell, the mitochondria have their own DNA. And this DNA produces the protein synthesis mechanism for producing some of the complexes in this electron transport chain. And it also produces all the mechanism to translate the message RNA produced by the DNA to make the protein. So when you have a mutation in a gene that its whole purpose is to replicate the mitochondrial DNA, you can see where there can be problems, because those subunits that are produced by the mitochondrial DNA become less. And there's a certain nadir that could be reached where those subunits no longer function efficiently and you produce less ATP. And that less ATP causes cell compromise, which can cause organ compromise, which can cause the organism to fail. So that protein or that gene is polymerase gamma. And that's the sole DNA replicase that's found in the cell that goes into the mitochondria to replicate the mitochondrial DNA. So that's sort of the background. The type of disease category is what we call a mitochondrial DNA maintenance disease. Polymerase gamma produces most of it, but there are other genes that produce some of it, and our quest is to figure out why and how these diseases progress. So there are at least 6 genes, but they're minor. The primary one is polymerase gamma 1. And as I said, it's nuclear encoded, so it's not inherited through the mother. So it's autosomal dominant or recessive, depending upon where the mutation is, and it's a nuclear gene. Now, let's see. Do I press? So what do we know a little bit about the disease? It's the most common mitochondrial disease. It causes about 20 to 25% of all mitochondrial diseases. And when you think about mitochondrial diseases, 1 in 4,000 has a mitochondrial disease. So pol gamma is very important in at least mitochondrial medicine, where I play my games at. The mutations within pol gamma are very interesting because one part of the protein is for the replication of DNA, and the other part of the protein is for proofreading, correcting the mistakes that the replicase makes. And it's all hooked together by what we call a linker region. Depending upon where the mutations are in that gene, it can be autosomal dominant, autosomal recessive. And when Bob Navio and I published the review of this disease, what we found is that this disease presents in infancy, and we diagnosed a patient with a similar disease at the age of 70 who had mutations in pol gamma. So you see it across the lifespan. So it's not only a pediatric disease, but it's actually an adult disease as well. Oops. So this is just a little cartoon of where the mutations lie. There are a bunch of them. There's over 87 pathological mutations in pol gamma. And there seems to be, in the pediatric age range, there are 2 groups. There's a pol gamma disease, Alper's Honeylocker syndrome, that's expressed early on in infants and young children. And then there's a second disease, same name, more prolonged disease that's less aggressive but still present, that occurs in the adolescent to the young adult. So the young disease usually occurs between 1 and 5. Harold of the disease is usually seizures. They can be indolent, easily treatable, and then they evolve into an intractable epilepsy, or they can be just robust and present in status epilepticus. When seizures start, you see a neurocognitive decline, and it's progressively relentless. Seizures become intractable to medication. Then the liver gets involved, maybe, usually about 80% of the time. And the children usually don't die from their epilepsy. They usually die from their liver disease, or they die in status. It's progressive from the time of diagnosis to the time of death, somewhere around 2 to 4 years of age. So it's progressive and relentless. The second form is what we call Juveniles Honeylocker syndrome. And usually the child is normal to the teenage years, maybe migraine headaches, maybe some learning problems, but mostly pretty normal. Seizures, again, are often their heralding symptom of this disorder, sometimes in status, sometimes just with indolent seizures. Eventually, they become uncontrolled as well. You can see cognitive decline, but that's more prolonged. So my first patient I picked up when I came here, she was actually a honors student in high school. She ended up writing for the Tacoma paper. And I passed her on to the adult service, and she was in her mid-20s. At that time, the hospital kind of let me see older patients. And her demise was somebody gave her valproic acid for her myoclonus, which caused liver failure. But she had lived a decade and a half with her disease. In the literature, we found that the early reports were adults that were in their 50s and 60s with this disorder. So it can be rather long-lived. So genetically, we have a youngster and we have a teenager young adult. The young disease is more virulent. People die young. It's a terrible disease. The juvenile form, people live longer. They can have maybe a good quality of life. There is one patient in Europe who's walking around 15 years out of her liver transplant. She's still walking. She's taking care of her family. So there's definitely this gray area of the older onset patient. And the genetic mutations. Usually in the adolescent form, it's a homozygous recessive mutation. And it's usually found in the linker region. And most of the mutations are, it's not really important, but it's 467 mutation that's homozygous. The compound heterozygotes are usually the more virulent disease, and those are the diseases that you usually see in the youngsters. There's overlap, and we don't clearly understand why. So let's put the picture together. So Alper's Honeylocker syndrome is a group of disorders that there are two populations, youngsters and juveniles. It's mainly due to one mutation or series of mutations in one gene, polymerase gamma. Seizures are very common. Status epilepticus is common. The treatment of status is usually good. We usually are able to get kids out of status, but seizures are definitely a problem. Liver failure can be present. There is cognitive decline. And the degrees of which the two latter symptoms depend upon which group you fall into, how quickly the disease progresses. And I think that's my part.
So the solution to this was really straightforward and simple. And we spent about 3 days talking for several hours a day with no fewer than 10 or 12 people in the room, all of which were incredibly smart and all of which really wanted to do the best thing for this child and her family. And I don't think it was at all clear on what we should do. And one of the things that came out of this was to assure that the family understood this difference between probably the tone of which the information was presented to the family was more along the tone that you would present with the infantile form of really rapidly progressive, relentless progression of disease, and less so of the optimism of a disease process that has a high likelihood of being progressive, but at an unknown rate. And we clarified with the family that they understood that there was a chance of recovery. There was a chance of even decades of a reasonable quality of life. But they really hung on to the words of cognitive decline, seizures, and liver failure as being the ultimate outcome for their daughter. And they stood steadfast that what she would want and what they wanted was for us to withdraw care. So this went to the ethics committee with the main question of whether it's appropriate to respect the parental wishes to limit care, with the possibility that Jennifer would die. Now, we suspected that she would continue to breathe and that she wouldn't die if we just extubated her. But this would lead the course to the next set of questions in terms of whether or not it's reasonable to withhold antibiotics or to withhold other life-saving therapies for Jennifer. And I think, I can, yeah. So we've talked a lot about this, and this, for me and for many of those of us that were caring for, really brought up some big questions. And I think one of them is whether or not there are thresholds about an assessment of quality of life or above or below which parents cannot decide to provide or withhold life-sustaining interventions. Interventions. And I think this is important as we think about this, because we all come to the table with our own sense of what's a reasonable quality of life. What would we want for ourselves? What would we want for our loved ones? And when we're thinking about this for a child, we have to think about it in terms of what they would want after they became 18. We can't really do it for what they would want now. And so there is a difference between adults and there's a difference between infants, but what about a 14-year-old or a 17 and 12 months old? Does it matter if the concern is about likelihood of survival or cognitive decline? Is it just an issue of quality of life or quality of death? And would the answer be different if the expected decline in liver failure was not from genetic but from some other self-induced mechanism, like probably the most common one in adults, which is alcoholism? And the last one is something that I particularly struggled with, as we have worked hard to provide what we would consider a good quality of death in the ICU. How do we reconcile that we can't be certain about her recovery and that the family may regret that we overrode their wishes?
And actually, before I bring Bob up, I want to, if there's any quick clarifying questions for either Lincoln or Russ, let me know, and we can try to answer those really quickly before I turn over to Bob. Yes?
Did she continue to have seizures when they took her out of her coma?
No, the seizures stopped.
Yeah, for those listening on the tape, the question was whether her seizures continued after the coma was stopped and the seizures had stopped.
She was quite purposeful, quite interactive.
Yes. There you go.
She's quite purposeful, quite interactive, with really high, what I would consider high cognitive function. Awareness of her surroundings, interactive. Sid?
so the question was asking about the genotype of this patient, and the genotype was the 467 homozygous mutation. So if you put them in a box, that would be classic for the more juvenile form. We should probably go ahead and,
Okay.
What was the status of her liver?
At least based on synthetic, the question was regarding the status of her liver, and regarding synthetic function, it was normal. Now, albeit there are some hyperbilirubinemia that we see with long-term phenobarbital use, but in large part, at that time, it was normal.
There's a clicker? Tom will have to click that. We're trying to find it.
All right.
Oh, here it is. Yeah.
I can use the computer if it's all right. I'll use this. All right, good morning, everyone. It's great to be here. Thank you for being here as well. When I was thinking last weekend about what I was going to say today, I was hoping I could joke with you a little bit about whether the Seahawks or the New England Patriots were going to win the Super Bowl. Unfortunately, worked out a lot better for you than it did for me. But I think it's probably going to be a better game. I think the Seahawks would have decimated the Patriots. So I think it'll probably be better as it turned out. Boy, there's so much to talk about with this case. I'm going to try to keep my comments fairly brief so we have lots of time for discussion. Whoops, let's see here. All right, so I thought I would start with this first question that was at the top that I think is maybe one of the most interesting questions. Are there thresholds about the assessment of quality of life above or below which parents cannot decide to provide or withhold life-sustaining interventions? So I tend to think somewhat visually, and so I might think about quality of life here as along a scale, and if we have very poor quality of life down on the left and high quality of life over on the right, how should we think about these questions of, is there a lower bound where we may say that parents may not demand treatment? And how do we think about an upper bound where parents may not refuse treatment? Okay? Now, I think that lower bound is actually fairly black and white. That lower bound is defined by what we call brain death. And at that point, when a patient meets those criteria, we would say that parents can no longer demand treatment. Although, if you've been reading the papers, you know that there was a case in Oakland recently that really calls that into question, Jahai McMath, where her parents have demanded that they continue to provide treatment. And warning, I'm about to say something very controversial and unpopular, but I actually think that the parents have a point here. I think that there's truly very little about Jahai McMath that is dead. She is never going to wake up. She's going to need a ventilator for as long as she lives. But you know, now that they found a place for her to be ventilated and to be fed, she could live for a number of years. There's many case reports of this. And so I think we're sort of overplaying our hand to insist that this corpse is going to be surviving for a number of years. But that's a side point. I do think that what brain death does for us is that it's not necessarily a definition of death, in my view, but it is a legal definition of medical futility. So that when patients meet these criteria, we can say that we as a society have no obligation to, and indeed should not, continue to provide life support for them. Now, the question of where parents may not refuse treatment is a lot more complicated. You know, do we draw the line here, let's say, maybe for a patient in a persistent vegetative state? Now, certainly if the parents want to continue treatment, we say that they can, but most of us are pretty comfortable with the idea that if they don't want to, we should stop. But, you know, as it sort of moves up this quality of life spectrum, it becomes more difficult. So here, you know, we're still in the green. We may still think that that's okay. Here we might say, I'm not feeling as comfortable anymore. And, you know, we get out to here more into the pink zone, and we're thinking, I don't think that we should allow the parents to refuse treatment in this setting. So what are the factors that go into where that line is drawn? There's a number of them. The degree of cognitive disability, the degree of physical disability, how those play out over time, how long the patient is going to live, the pain and suffering that's associated with continuing their life, and there's more. I mean, this is just a partial list. But I want to make a simple point about this, but I think a very important point. And that is that all of these variables are what we call incommensurate. What do I mean by that? I mean that within any one of these, we may be able to rank what's better or worse. So for example, we could say that living with a pain score of 2 out of 10 is better than living with a pain score of 8 out of 10. Or living for 10 years is better than living only for 1 year. So within each of these, we can talk about how to rank quality. But we have to put them together. And when we do that, there is no definitive way of balancing them. So if we ask, does living for 10 years with a pain score of 8 better or worse than living for 1 year with a pain score of 2? There is no method by which we can answer that question. It's going to be highly variable. And the bottom line here is that reasonable people may disagree. Or to put it another way, when we disagree, as we often do, no one is being unreasonable. And so, I think that this is what makes cases like this so difficult. Now, one of the things that comes up is, well, since these are difficult questions, why don't we let the patient decide for him or herself? And I think that this is good in theory, but I think in most cases like this, it doesn't work very well in practice. There's some literature about before withdrawing life support, trying to wake people up from the sedation in the ICU, or in this case, is there a difference between her being 14 or 18 years old or 30 years old? To be honest with you, in my experience, there's not much difference in all of those. If patients are sedated in the ICU, there's usually a reason why they need to be sedated. And if you start to lighten up that sedation, you have a problem. But even if they can wake up to some extent, as this girl has, is she really capable of making these kinds of decisions for herself? People coming out of a serious illness typically are decisionally impaired. They may still have remnants of ICU delirium. They may be depressed. And so I would say, independent of her age or sedation or anything else, we're not going to get away from the fact that in this case, the decisions are going to have to be made between her parents or surrogate, if she was older, and the clinicians taking care of her. Now, I want to talk a little bit about what we do when we decide to withdraw life support, as was the question on the table here. What is it that we mean by this? Do we mean, for example, that in making this decision, we predict that she won't survive, even if we continue to provide life support? Or are we saying something else, like we don't know if she will survive, but even if she does, the burdens of life will exceed the benefits? I got to thinking about this a lot a few years ago when we had a case in Massachusetts. I'll just tell you about briefly. The child's name was Haley Pudra, and she was a little girl, 2 or 3 years old, whose mother's boyfriend beat her up, and she was left with very severe brain damage. And she was at another pediatric ICU in the state. And the intensivists there felt that given her very poor prognosis, that they would recommend withdrawal of life support with the expectation that she would die. Now, under the usual circumstances, conversations would have been had with the family, and probably over a few days or a week or so, that decision would have been made, life support would have been withdrawn, and she would have died. But given the circumstances and her being a ward of the state, you had to get the approval of a judge. And this took a couple of months. And by the time the decision was actually going to be made, she had started to open her eyes and was responding some to pain. Now, when this was in the papers, as it was presented in the Boston Globe and elsewhere as the doctors made a horrible mistake. Can you believe this? They said that we should withdraw life support, and now she's improving. And the judge said the same thing, I'm removing this DNR order, it's full steam ahead. And the clinicians who were involved also implied in the limited statements that they made that they had made a mistake. And I'm thinking about this, and I'm a pediatric intensive care physician, and I don't know the case in detail. It wasn't at my hospital, but from everything I heard, it seemed quite reasonable that they had recommended withdrawal of life support. But I don't think that in so doing, they were necessarily saying that she wasn't going to survive. She may not survive, she may, but they were saying that regardless, the outcome probably would be poor enough that the withdrawal was justified. And indeed, we don't know the details because of privacy, but from all I can tell, she has gone on now. She's still alive, but I think she's either in a persistent vegetative state or a minimally conscious state. And I don't think that the decision that those physicians made to withdraw life support was necessarily wrong. We can often predict that patients will improve over time. That doesn't mean that these earlier decisions to withdraw were wrong. And I think that some of these factors are present in this case here. Now that she's getting better, does that mean that that decision that was made earlier to withdraw life support was an error? I don't necessarily think that's true. And that kind of relates to another sort of concept I'd like to discuss with you, and it's the so-called window of opportunity. And I know many of you know what I'm talking about here. It's a term you need to use carefully because it can be taken to sound extremely cynical. And for that reason, not much has been written about it. I did put an article there by Dom Wilkinson that does discuss it. Again, many of you know about this, but let me describe it briefly for those who don't. And it's a conversation that I might have with a family in the ICU. To say, your daughter, unfortunately, has a very profound neurological injury. I don't think that she's ever going to be able to interact with you, to recognize you, those sorts of things. And that one pathway here would be to withdraw the ventilator and allow her to die. And that would be a very caring and loving decision that parents could make and one we would support. On the other hand, sometimes parents aren't ready for that this soon, and some parents may choose to continue on. That could also be very caring and loving and a decision we would also support, but it does have some implications, and we saw them play out here, is that by not withdrawing life support now during the acute phase of the illness, it's more likely that your child will survive after withdrawal of life support. And that can be comforting for parents because they can become more sure of the prognosis of how things are going to turn out. But it comes with some consequences in that decision-making after that can become more difficult. Sure, there may be intercurrent illnesses, pneumonias and things like that, where the parents can choose, should we opt for curative treatment or should we opt for comfort treatment? Or they may make a decision, as is being discussed here, as to whether to stop artificial nutrition and hydration. But the decisions become more complex over time, and often the very fact that a family has committed to a course of action can make it difficult for them to back away from that. And so this is sort of that so-called window of opportunity where if you withdraw life support early on, more likely that the child will die, and this more complex pathway of decision-making can be avoided. Now, I didn't quite realize in the earlier slides that I saw that in fact it looks like perhaps you were already out of this window of opportunity by the time the decisions had to be made. And so you had, if there is an advantage of being in here, that time was lost. Very last thing I'd like to comment on is the issue of team dynamics in decision making. So we've talked about the complexity of the factors that go into deciding where parents can make decisions to withdraw life support. And again, I'll speak mostly to my situation here and my experience. In the ICU where I work, we cover 7 days at a time. And that's not a real long time, but it's long enough to have some very intense relationships with parents. And usually when I'm on service, there's one or two of these situations that are going on. And we'll go through all of these things. And ideally, what I want to be doing as the attending is bringing out the values and preferences of the family, finding out how they think about these issues so that they can make the choice that is most authentic for them as individuals, as parents, as a couple, the one that is most genuine for them. Now that's the ideal. But our literature tells us that, in fact, my biases, my values, my preferences are inevitably going to come through. As hard as I try to stay neutral, I am going to be influencing how this family thinks about these things. And it really is going to be a decision that is going to reflect my views as well as theirs. And so the end of that 7-day period comes up, and I'm handing off to my next attending, and we're walking around the unit, and I say something like, I've been talking with his family all week. I think, they're coming around to the view that they're ready to withdraw life support. I think that will probably happen in the next couple of days. And my friend and colleague will look at me and go, withdraw life support? Really? And I can tell that, not convinced. And this is where I think these dynamics come in, because these conversations have been so hard for me that I've become rather wed to the rightness of them, that it's not just a right pathway, but that it is more like the right pathway. And, it is very hard then to back away and say, well, there might be another way of looking at this. And I think it's just human nature. I think it's hard for all of us. But I think to be able to recognize that and to see the way that we can become attached to our own decisions and to develop the ability to step away from that is difficult, but I think is necessary. Now, this case was further complicated by the fact that it seemed that information about the prognosis was also shifting over time. So it wasn't that the teams were dealing with a stable set of facts, that was changing as well. But I wanted to stay brief, and so these were just some of the thoughts where I thought we could initiate a discussion, and let's go on and do that.
And again, so what I'd like to do is, Bob can moderate the discussion, but have people come to the microphones for the questions you have, and then we can call on them. So, questions, comments, thoughts about these issues? Well, I will. Here we go. That's Doug. Okay. Usually over time, more people come on down.
So, the one question that hasn't really been answered, I think, is the hardest one, which is, would it be okay to withhold and withdraw fluids and nutrition in a case like this?
Well, I tried to stay away from that. Truly, it's very presumptuous for somebody like me to come in, don't know the case from outside, and begin to say what should have been done. I refuse to do that. It's not my place at all. It does seem to me that one of the factors that stands out is the way that the thoughts about the prognosis were evolving over time. That it went from a situation that really sounded dismal to one that sounded much more uncertain. And, maybe as I was reflecting here about how once we become committed to a certain view, it's difficult to let go of, I wonder if that was true for the family in this case. That having heard this dismal prognosis, having brought themselves, I'm sure, with great pain and difficulty to this decision to allow their daughter to die, it might have just been very difficult for them to reconsider that after having gone through all of that. So I don't know what the right choice is here, but the shifting prognosis, I think, makes this a much more difficult case.
Since you're in the glorious state of Washington, which has another alternative, and that is this family may in fact exercise, and that is in this state there is a right to death. And so now she survives and in fact begins to deteriorate and continues to deteriorate. This family is now facing another question. Comes back to do we provide water and nutrition? What about her right to die when she is no longer functional?
Well, I think that the right of surrogates to make decisions about artificial nutrition and hydration is fairly well established. I'm not an expert on your law in Washington by any means, but it is assisted dying. I would think that would need her full and competent involvement in the decision, as well as her involvement in taking the medications, et cetera. Whether she could get to the point that she could make that choice for herself is, if she did, That would definitely be on the table. But short of that, I don't think that's a decision that her parents could make for her.
I guess one of the problems I'm having is the notion that the default here is not to, in an instance in which there seems to be certainly a very real possibility that there could be a long life ahead of this person, and even perhaps not a particularly impaired life, at least for some period of time, given the uncertainties, that the default shouldn't be that would be the decision that a young adult or a cognitively incapacity teenager or young adult would make. I mean, I think that the notion that wouldn't be the case seems to me a hard one to make. And remembering that, in fact, it's not. That's the focus. The focus has to be, what do we presume? What would a reasonable person presume to be the decision that a young adult might make?
Yeah, I mean, I think you make a good point, and yet we have, at least by report, the parents saying that we know our daughter, and she would not want continuation of life support. So then that maybe sounds like not the typical sort of thing that an adolescent would make, but it needs to go into the scales that that's what her parents think.
Thanks, Bob. I'd just like to have you address one thing that I found also particularly troubling, which was just this concept of uncertainty. So in traumatic brain injury or after surgery or after a discrete event where you know that this area of the brain was affected, tumor, right, we have some pretty good data that tell us that these are the odds, these are the chances, this is what you're looking at. You can expect X and Y and Z. And one of the things about this that struck me was, well, maybe she'll have recovery and pretty good function for 20 or 30 years, and maybe she'll continue to seize and have cognitive decline and liver failure. And doesn't that very uncertainty widen the scope of what's a reasonable decision rather than narrow it?
I see your point. I don't necessarily know that I agree with it, because one of the ways of responding to profound uncertainty is to let things play out a little further, and hopefully that uncertainty begins to narrow. I mean, I think that in daily life, that's often how we deal with uncertainty. Not to just respond, well, since it's so uncertain, any choice must be okay. And you do have an option here of seeing how things play out. Now, in all fairness, you know, you've got these problems of pain and suffering going on here as well, and I think that one could argue that letting them play out too long would not be fair to the child, but in the short term, maybe?
Hi. One of the things that we sometimes hear from families is their concern about the impact of a sick or disabled child on the other children in the family, or on the marriage, or on the financial stability of the family. And I don't see impact of the family on your rubric, and I'm wondering how much, if at all, you think it's reasonable for the impact of a child's illness on the family to be part of the calculation about the withdrawal of life support.
Well, thank you for asking that question. It's a question I love. Can we factor the interests of the family into these kinds of decision making? I think that the standard answer in bioethics is no, that the only thing that counts is the best interest of the patient. I think we have adopted that because it simplifies matters, but I think it's not realistic. I think that families always take into account how decisions for individual children impact the family. You know, we're gonna send your sister to summer camp and you get to go next year, or you know, violin lessons for one and private school for the other. I mean, families are always balancing these issues one against the other, and I think it should be no different in medical decision making. And I think that families will sometimes, I won't go on too long here, but I think families will sometimes learn a code language in the hospital. They'll know that if they say something like, wow, I don't know how we're going to be able to afford this. I think that this is going to devastate us financially. We won't be able to send the other kids to college. That those sorts of considerations are prohibited from being a part of the conversation. So families know they learn how to talk in terms of child-centric language. She's suffering so much she wouldn't want to live like this. And I think we end up having somewhat distorted conversations with families because we don't allow these other considerations to come into play. So I would definitely add it to the list. I think it needs to be tempered just like anything else. It's not just about the family. The child's interests are predominant, but family interests should play a role.
So, Bob, when Lincoln, Russ, and I were making up the questions, one of the questions I put on there, which I wanted you to address briefly, was what was the third question, which had to do with whether this case might look different if rather than the etiology of her prognosis was related to a genetic condition, but whether it was some other both more common adult condition, one that is more complex. And the example I was thinking of was alcoholism, because alcoholism in its most severe form is associated with cognitive decline and liver failure. And I was and I found myself when I heard about this case visualizing how would this play out again if this was a 30-year-old in an ICU who had a family where the thought was, well, this person may recover, but this disease of alcoholism is not going to get better. And we can predict that this person will remain homeless, will have lots of other problems. And would that be a more or less reason to defer to the family's wishes about whether to continue interventions or not?
Well, stay there, Ben, because let me. I mean, I don't think that's as hard a question as it may seem, because so much of that hinges upon how we have evolved in the way that we view addictions. I mean, I do think that people have personal responsibility for their health, and we have less obligation to people who have brought their own problems down upon themselves. But that is a very complicated thing when it comes to the addictions, as you know. And the old view was that alcoholics should not be given liver transplants. They did this to themselves. They don't deserve it. And as we've moved towards a disease model of addictions and other things, then we see them more like a genetic problem. And so it does seem to me to pretty much hinge on where you come down on that point. And if you do take the firm disease model about alcoholism or smoking or those sorts of things, then we ought to treat them just like we do the genetic diseases. Might be a little more difficult for us emotionally to do that, but that would seem to be the right choice. And would you disagree with that?
No, in fact, part of why I raised this question, I thought it was in the opposite perspective. It's hard for me to imagine in the context of a family of an adult with alcoholism for how that clinicians would not respond if the family says, this has been really hard on us.
Oh, I see where you're going with that.
This has been very hard on our family. And in fact, we don't think he really likes what he's doing. So we think, don't wake him up. Don't allow him to recover. we have our window of opportunity. That's how I was thinking. My sense is that we'd say, wait a second. That's a problem. It seems for genetics, that sounds even more fatalistic than even alcoholism. I was coming from the opposite perspective.
I got it. Okay, I see your point. Okay, yeah.
I'd like to raise what I think is an operational issue that has ethical implications. You talked about the moment when you hand off to another physician who looks at things quite differently than you did. Do you have any suggestions about how do we help the family through that change, radical change in the team?
What a great question. I wish I had a great answer. This is, of course, it's both a problem and a benefit of the fragmented system that we have. The fact that those attendings are changing, that our house staff is changing, brings new perspectives to cases that you don't get when you've got a single provider over time. But it does come with this roller coaster for families of getting advice that, could be radically different from one day to the next. And how do we appropriately translate for them in a way that makes sense to them? So acknowledge that that's a really, really important point.
My question was very much related to that, is what are the ethical responsibilities of the attending physician when signing off a service to continue involvement with the family in a particularly difficult situation like this, where building that trusting, supportive relationship over sometimes hours, days, maybe even weeks cannot be, the family would say, why are you leaving the service to go do research or administrative work or work at another hospital? This is more important than that. So how do we negotiate that ethical landscape?
Yeah, well, just really briefly, we in my ICU have tried to address that with the assignment of continuity attendings. The fact is, though, it doesn't work all that well. I mean, I just went off service a few days ago. Here I am in Seattle. I'm not available. So I think we've recognized it as a problem, and but I think the solutions are imperfect. Yeah.
A comment, and I'd appreciate your response to this 17-year-old who apparently has told her parents what her wishes would be in a medical catastrophe. Several months ago in the New York Times, there was an article about a renowned bioethicist who was a strong proponent of right to die. She travels extensively, lectures extensively. Her husband experiences a high cervical cord injury, but can return to his job as a university professor and with some assistance teaches at the university level. But he expresses to his wife that should he have a sudden medical emergency, he wants no medical intervention and wants to die. So what happens? He has a medical emergency. His wife, who is a strong proponent of right to die, goes against his wishes, tells the medical team to do everything possible, and then is distraught about when her husband, if he survives, what his response is going to be. He survives and tells her thank you for not following his wishes. And so I'd just be interested in your response to that, and how I think it clouds this issue of medical decision making.
So, well, I would encourage those of you who want to think about this case to actually read the article that Peggy Batten wrote about the care of her husband, because it's very nuanced. But just in a sentence, I think that one way to look at that is the problem is that we tend to think in terms of the procedures that we will or will not provide rather than the underlying goals and intentions of the patient. He said in most cases, I don't want to be resuscitated, but that's always more complicated. It's going to depend upon the context, upon the circumstances. And who but somebody that we love to be able to really think through the decision in the moment and try to sort out what would my husband really want in this moment. She did the best she could. It turned out she made the right choice. Of course, he did, since then, decide to forego life support, and he has died. So I just think that these decisions are more complex than, oh, you have a DNR order. I guess that means you don't want to be resuscitated under any circumstances. It's almost always more complex.
Thank you, Bob. I want to thank Bob as well as Russ and Lincoln for their presentations and you for your questions. I do have a couple quick announcements that I forgot to make earlier. The first is that Bob will be doing a seminar down at our Truman Katz Center at now the Jack McDonald building, or about to be the Jack McDonald building, formerly Building 1. And he'll be talking about the issues of organ transplant in children with profound disabilities, and that'll be at 3 o'clock. Our next of these grand rounds actually won't be for another year from now, because in the fall we have our Truman Katz lectureship, which is a more traditional style grand rounds, which our presenter will be Steve Jaffe from the University of Pennsylvania. But I also want to mention next January will be our next one of these, and we're always looking for cases and issues that people want to bring. And some of them come from our ethics consult service, but if you have ones that you're just thinking about, come talk to any one of us from the Bioethics Center, and we'll be happy to involve you with that. And I see it must be another announcement.
Well, that's right. One more announcement, may I?
Please.
I suspect a lot of people who are here today will also be interested to come back next Monday at noon for Schwartz Center rounds. The topic next Monday is going to be two very thoughtful people, Bob Perlman from the VA and Doug Opel from here, talking about suffering in the context of disease, that is what we treat, and illness, what the patient actually experiences, and the complicated relationship between evidence-based medicine and personhood. So if you can, please come back at noon next Monday, and you get a free lunch.
And actually, your last comment made me remind me of one more announcement. On March 10th at 11:30, we'll be showing the film Rare, which is a very unique documentary about the experience of a family in a clinical research trial, and Holly Tabor will be leading a panel discussion after that. So keep your eyes open for that as well, too. Thank you.